Good evening, everyone. The clinical role of insulin glargine will be discussed today in today's meeting, and we'll be talking about the beta cell crisis and how do you tackle, what are the steps to take to prevent the beta cell decline. And as I was telling you, beta cell decline is a progressive course in the natural history of diabetes. Insulin beta cells are the ones which produce insulin, and over a period of time, the beta cells get progressively reduced in number, and therefore the decline sets in over a period of time, say from the early 20s, 30s, and as days progresses, the decline gets faster. So what are the steps? And then patients become initially pre-diabetic when you can just about manage the sugar control by increasing the insulin level, but gradually as time goes, more beta cells are lost, the insulin levels decline, and the patient becomes frankly diabetic. So the drugs and the newer therapies that are now there are there to help in preserving the beta cells. There are certain drugs which help in depletion of beta cells, and I'm going to discuss which ones to choose. And the core of diabetes physiology should be understood. As I was saying, initially with passage of time, beta cell dysfunction sets in. Beta cells are the ones which produce insulin from the pancreas. And if that cells are affected, the insulin production is also affected. Blood sugar gets worsened, the hyperglycemia progressively worsens, the glucotoxicity sets in, and the apoptosis of the beta cell necrosis sets in. If there is a high glucose in the blood, the beta cells can't function properly. How to preserve beta cell and preserve life? That is the talk of the day today. And the difference between progression and preservation lies in protecting the beta cells that remain functional. So one has to pick up the good beta cells and see whether you can prolong their life and protect them from destruction, and so that they can have a long life and the insulin production can also be restored. That is the talk of the day, and we'll see what are the agents or better insulins which are there in the market which will help us in preserving the beta cells. Why the early use of basal insulin is recommended? Because the beta cell first hypothesis is certain to trap. And as I was saying, the glucotoxicity trap is very vicious for the patient. One has to break the cycle of glucotoxicity, because glucotoxicity or high blood sugar in the circulation can lead to damage of the beta cells, and the beta cells progressively decline. Therefore, if we can address this issue by tackling glucotoxicity by giving certain basal insulins which act by preserving the beta cells and putting less pressure on the endogenous insulin production, then that can help the patient to come out of this beta cell toxicity, and the patient can lead a better life by managing the sugar in a better way. So the basal insulins will help in the impaired insulin secretion. Insulin secretion is impaired from chronic hyperglycemia because they disrupt the pulsatile insulin release pattern. The postprandial surge of insulin release is impaired after the glucotoxicity sets in. The beta cell damage threshold is reached. The fasting plasma glucose gets more than 6.4, or in certain terms, if we talk in milligram, the fasting levels, if it climbs above 250, it triggers progressive beta cell injury. Along with that, the postprandial sugar also goes above 300, HbA1c goes above 8-9%, then the damage gets more amplified. And the vicious cycle sets in, worsening the insulin resistance and beta cell failure. They perpetuate each other. As you know, insulin resistance and beta cell failure are the core defects in type 2 diabetes. If insulin resistance worsens, the beta cells progressively decline further, and it's like a two-way vice versa effect. And ultimately, the total system gets collapsed and glucotoxicity sets in. So we have to take steps to intervene by giving basal insulin at this stage of glucotoxicity to prevent the beta cell failure from exhaustion and decay, and so that the blood sugar gets well controlled and the insulin resistance improves. The beta cells also function well in a period of time. The insulin reserves ultimately also improve. Why basal early insulin? The beta cell first hypothesis has been very much set into motion. The one has to, whatever drugs or insulin you give to the patient, first thing that should be in your mind is to protect the beta cells from decline. And you have to make sure the beta cell repletion takes place, the patient gets stabilized. So that is the thing that I'm trying to focus. How do you protect the beta cell? So early insulin therapy is no doubt the best therapy. It helps in beyond glycemic control. If you can give insulin from outside, exogenous insulin, it gives the beta cell rest, because the beta cells, the pancreas, are gradually getting exhausted. It reduces the glucotoxicity, provides beta cell rest, and enables recovery of insulin secretory function. It improves the endogenous secretion, demonstrable, measurable of insulin resistance is also improved, and alters the disease trajectory. It has got the potential to delay progression and prevent long-term complications. So these are the three important steps if you can address by giving early insulin, especially basal insulin. And we have landmark clinical evidences. The insulin glargine study in early type 2 diabetes was one of the early studies which was done. The 6.5-year follow-up study was done, and it was seen that the long-term composition of insulin glargine plus oral agents versus standard care demonstrates sustained benefits in glycemic control and metabolic parameters. This was a study where conventional therapy with lifestyle and diet were seen in one hand. On the other hand, received intensive therapy with insulin glargine plus oral agents, whatever be it metformin or sulfonylureas. And then it was seen that the group which received the insulin glargine, the results were better in the long term. The beta cell reserve was preserved in the insulin glargine arm, and the insulin sensitivity improved, and the glucotoxicity was also controlled. That was the study. And the fasting sugar ultimately came down very well, followed by postprandial sugar reduction and ultimately lowering of A1C and better glycemic control. So now the clinical trial spotlights are showing that beta cell function preservation study was done where the pivotal trial compared insulin glargine versus sulfonylurea therapy, especially measuring beta cell function preservation over time. Early basal insulin demonstrated superior outcomes in maintaining endogenous insulin secretory capacity and reducing beta cell stress markers. So one group had sulfonylurea, which is fatal to cause insulin and beta cell exhaustion. As you know, sulfonylureas are very notorious drugs. They help in controlling the sugar initially, but later gradually the fatigue sets and the beta cells get depleted. That group which received sulfonylurea was compared with the group which received basal insulin glargine. It was seen that the basal insulin glargine group fared well in terms of beta cell preservation, because if you give basal insulin exogenous from outside, it helps in improving the insulin sensitivity. Ultimately, the endogenous insulin secretion of the beta cell is also increased by giving them beta cell has got rest, so they regenerate and function better in the long term without giving basal insulin. And the beta cell stress markers are also reduced. So when a stage like glucotoxicity sets in, you have to realize you have to call it a day. The insulin factory, the pancreas needs rest. The lockout is there in the factory. So from that's why you have to give insulin, exogenous insulins. Basal insulins are the best insulins to start insulin. Has to be given initiated so that the beta cells get more rest and they get time to regenerate. Ultimately, the sugar control becomes better with exogenous insulin because the insulin resistance gets down. And beta cell secretory capacity also improves in the period of time. So there is no doubt that beta cell to reserve the beta cell function, basal insulins have a very good strong role. It has definitely shown much better effect than sulfonylurea, which caused progressive depletion of beta cell. That was the trial spotlight, and that was the main thing of the study. Now, what is the mechanism of action of insulin glargine? Glargine is a unique molecule. Understanding the unique pharmacological properties that enable once daily basal insulin coverage and physiological glucose control is pivotal in the understanding of management of diabetes. As you know, insulin glargine comes as monomolecules, monomers, and dimers, and one has to be injected subcutaneously. And how the insulin glargine is a long-acting basal insulin analog that will be discussed now. What is the prolonged what is the physiological mechanism of the long action? Because if you inject it once daily, action is sometimes 24 hours or even more, 28 or 36 hours. Therefore, it is so important to know the insulin structure, the pharmacodynamics and pharmacokinetics. Very important, should be understood. One has to understand that the superior glycemic stability is there. The sustained mechanism forms microprecipitates in subcutaneous tissue, allowing gradual absorption to the bloodstream. This results in get better absorption control. So insulin glargine is a long-acting basal insulin, and it has got a modified structure. It is engineered human insulin analog with specific amino acid substitutions enabling prolonged action. Number two is the peakless profile, which is the unique characteristic of the molecule. It has got a steady graph throughout the day. The peakless profile provides steady approximately 24-hour basal insulin coverage, mimicking physiological secretion. The third is once daily dosing. Convenient subcutaneous injection ensures sustained glucose control throughout the day if you give it once a day. These are the three important advantages: modified structure of the molecule, the unique molecule structure. If you can inject it subcutaneously, it helps in peakless profile. Also, it's once daily drug, which acts throughout 24 hours. The pharmacodynamics and pharmacokinetics of the molecule have to be understood. The molecules form hexamers or microprecipitation. And from the hexamer, sustained release of the molecule occurs. The superior glycemic stability is because the sustained release mechanism forms microprecipitates in subcutaneous tissue, allowing gradual absorption into the bloodstream. This results in reduced glycemic variability and significantly lower hyperglycemia risk compared to NPH insulin. Particularly nocturnal hypoglycemia is much less with basal insulin. Therefore, this is so important to realize that if you give this injection once daily, chances of controlling the fasting sugar, the A1C is much better than very low chance of nocturnal hypoglycemia when you compare it to the conventional NPH or the premix insulins. It is the big advantage of this molecule, basal insulin, insulin glargine. What are the clinical benefits of insulin glargine and beta cell preservation that is going to be talked about now? Translating mechanism into measurable clinical outcome that preserve beta cell function and alter disease progression is the main core of the molecule. If we inject this basal insulin, it will help in preserving the beta cell, as I said from the beginning. It will also alter the disease progression and will provide better control of the glycemic sugar. Control will be better, and the other complications of diabetes will also be less, because we know that if you can control the blood sugar well, if you can bring down your fasting postprandial sugar, also if you can fix up the HbA1c below 7%, the chances of microvascular complications are directly related to better glycemic control are much less, and also the chances of macrovascular complications are also less, like cardiovascular disease and renal disease. The ultimate thing that we all should try to do is to control the sugar levels very adequately. We must make sure that the fasting sugars come down near 100. You have to fix the fasting first with the basal insulin when it is given at night. After fasting is fixed, then the A1C will try to calm down, but you have to look at the postprandial sugar then. If the postprandial sugar is high, then you have to control it by giving certain drugs which will help in control of prandial sugar. Ultimately, the HbA1c will come down further when the fasting and postprandial are well controlled. The A1C will also be lowered, and ultimately the complications from the point of microvascular and macrovascular complications will be lessened with every 1% lowering of A1C. So it's very important to control blood sugar in a very tight way to prevent the complications in the long run. So there is a comparative study where glargine versus metformin in early type 2 diabetes was done. It was a head-to-head comparison. The direct comparison reveals distinct benefits of each approach. Insulin glargine showing superior fasting glucose control and beta cell function improvement over metformin. But metformin demonstrates complementary benefits in microvascular blood flow, suggesting potential for combination therapy strategies. So as you see, glargine and metformin are seen separately. The glargine arm shows the better control. You see the bar diagram of glargine shows better glycemic control because of its important advantages, as I said, in beta cell preservation and controlling the A1C and fasting sugar. And if we compare it with metformin, metformin also helps by controlling the insulin resistance and working on the level of the liver and peripheral muscles. But ultimately, we can see that if you can complement these two mechanisms, the glargine and the metformin can be combined for better effect. Basal insulin is helping in recovery of the beta cell and ultimately more release of insulin from the beta cell. On the other hand, metformin is helping by reducing the insulin resistance at the peripheral level, so the insulin is more utilized properly. So if you can combine these two, basal insulin and metformin, it's a very good way to control the blood sugar, and because you are tackling both the mechanisms. The decreased beta cell production of insulin is being controlled by the basal insulin, ultimately, and the low and higher insulin resistance in the periphery is being controlled by metformin. So you understand why the synergistic combination is being so well effective in controlling diabetes. So the beta cell function improvement, what are the evidence summaries we have? We can see that the reduced beta cell workload definitely helped in preserving the beta cell. Early basal insulin therapy, the earlier you initiate in this situation, reduces glucotoxicity burden, allows pancreatic beta cells to rest, and recovers secretory function. That is the basic core principle why the beta cells are improving. If you give the insulin from outside, the basal insulin, the beta cells get prolonged rest. And if you give them rest, anybody recovers well. Suppose when you're ill, you need rest, because the beta cells are going to be diseased. So if you give them rest, ultimately they recover and the secretory function improves. That is number one. Number two is the sustained insulin secretion is improved. Clinical trials demonstrate preservation of endogenous insulin secretion capacity over extended follow-up periods. Ultimately, if you see and follow up these patients, you see that ultimately the endogenous insulin production is increased over a period of time because the beta cells get enough rest to regenerate and produce more insulin. Number three is the long-term disease modification. The potential to slow disease progression trajectory and reduce future insulin requirements through beta cell preservation is a must. If the beta cells are preserved, the disease process will also be halted. The complications like microvascular and macrovascular will also be reduced, and the patient will live a more stable and active life. So therefore, it's so important to give basal insulin from the beginning to control the glucotoxicity and to help the beta cells to recover. The glycemic outcomes of the insulin glargine are being continuously monitored from time to time. The most effective marker to see the reduction of blood sugar is the HbA1c reduction. How does insulin glargine fare when compared to the other treatments? Insulin glargine, one arm, The other arm is the treatment with A, suppose a drug treatment A, then treatment B and treatment C. A, B, C are the other treatments, and the insulin glargine arm is the treatment that we are comparing with. And the A1C reduction is assessed on the other side. We see that the proven efficacy there across studies. A lot of studies have been done over the last 25 years since glargine came to the market. Insulin glargine achieves A1C reduction comparable to other basal insulins and oral anti-diabetic agents in head-to-head comparisons. So we can see that whatever oral agents use, say SGLT2, DPP4, metformin, whatever agents have been compared with basal insulin, we see that the effectivity of the basal insulin is very good. It helps in better control of A1C like the other agents, but the big advantage of the basal insulin glargine is that it preserves the beta cells, it prevents decay of beta cells, and ultimately restores the functional capacity, the secretory capacity of beta cell is restored. So ultimately, you're doing more benefit to the patient by giving basal insulin from the beginning, by controlling the fasting sugar and the A1C very tightly from the beginning, so that the patient doesn't worsen further. So therefore, these studies are showing that we have to use this basal insulin from the very beginning in these patients of glucotoxicity and secondary OHA failure. The hypoglycemic risk again was assessed, and the safety of the molecule has been well established of insulin glargine. The safety advantage, understanding the hypoglycemia risk profile and effective insulin therapy implementation. As you know, some of the insulins, the previous ones that we had, the standard insulins that we used to give earlier, the regular insulins, the premix insulins, and some of the other insulins were good in controlling the postprandial load of sugar, but the main disadvantage was the hypoglycemia factor. The big advantage with basal insulin glargine is that you can give it once a day. It helps in control the fasting A1C and ultimately the postprandial, but the most biggest advantage is the very low incidence or minimum incidence of hypoglycemia. So the study was done where many studies show a slightly increased hypoglycemia risk compared to oral agents alone versus lower risk alternatives, and significantly reduced hypoglycemia was seen with compared to sulfonylurea and NPH insulin, as I was talking about. These two agents, sulfonylureas, NPH, and premix insulins, are notorious to cause hypoglycemia. So therefore, risk mitigation strategies have shown that patient education and careful dose titration are critical for minimizing hypoglycemia events. Patient has well explained about the dangers and the symptoms of hypoglycemia so that he can recognize it and record it early, and he has to know how to titrate the dose to prevent hypoglycemia. So all these factors have been taken into consideration. And there it was seen that basal insulins again fared the best because the chances of hypoglycemia were much lower compared to conventional therapy with sulfonylureas or therapy with other insulins like premix or NPH insulin. So definitely this drug scores big in terms of low chance of hypoglycemia. That's a big plus point for insulin glargine. The safety of the molecule is well established now that it's a very good drug for control, and the chance of hypoglycemia is minimum or negligible. What about the cardiovascular safety in high-risk patients? Nowadays, when we give anti-diabetic drugs or insulins, not only think of controlling the blood sugar, also think about the cardiovascular and renal protection of these agents. Most of the trials that are there in the market show that whatever agent you use, SGLT2, GLP-1 analog, DPP4, all the trials are being done to see whether they have anything beyond extra glycemic control. The extra glycemic benefits are the big plus points which should be always looked into. Most of the diabetic patients die of cardiovascular disease and its complications like heart failure or myocardial infarction. And the other important complication that we see in our diabetic patients is renal failure related complications leading to volume overload, pulmonary edema, heart failure, and sudden cardiac death. So these two complications, especially the cardiac and the renal complications, should be always assessed in terms of a new drug or insulin or molecule. The long-term data are reassuring because extended follow-up studies have not demonstrated any significant increase in adverse cardiovascular events with insulin glargine therapy, even in high-risk patient population. That is the big thing. Most of the patients have got diabetes plus other comorbid condition or other dysmetabolic syndrome, where diabetes is coexisting with hypertension, dyslipidemia, and obesity, and leading to a high chance of cardiovascular and renal disease. So in those group of patients, it has been seen that after giving insulin glargine, the chances of cardiac complications and renal complications haven't increased. It has been found to be protective to prevent it helps in protecting the patient not only from the sustained effects of high glycemia, but also it helps in protecting the patient from the cardiorenal viewpoint. So early and effective glycemic control may actually reduce long-term cardiovascular risk by mitigating the damaging effects of chronic glucotoxicity on the vascular system. So that is the thing. If you would allow the patient to progress with high blood sugar or Glucotoxicity will go on for a very long time. Higher the blood sugar, the higher the A1C, and how ultimately the damage at the endothelial macrovascular level will be much higher if your blood sugars are running very high. And if you can control the blood sugar very tightly from the beginning by giving basal insulin, the chances of cardiovascular complications and renal complications are much less. So therefore, this is a very good drug, basal insulin glargine, not only in controlling the blood sugar, but also it helps in controlling the complications of diabetes. And it has got a very favorable effect in preventing the cardiovascular renal complications of diabetes. Because that is the most body that we have in our mind when we see diabetic patients. They die, as I told you, mostly of renal failure and cardiovascular related problems. So if you can control this complications by giving certain agents like basal insulin, what better way to control diabetes? This is one of the best approaches. So insulin glargine in type 2 diabetes subphenotypes have also been assessed. So different patients are there with different phenotypes. As you see from this diagram, so one is centrally obesity, one has got thin diabetic, different in female elderly patients. All these things have been taken into consideration. So recognizing the diabetes heterogeneity to personalize insulin therapy for optimum beta cell preservation and glycemic outcomes will be something which will be discussed with basal insulin. So it works well in each class of patients. It is not just a drug which acts in a certain group of patients. Across the board, if you see, so like this board, there's a young guy, there's a young girl, and there's a middle-aged gentleman and an elderly lady. Across the spectrum, insulin glargine has shown good effects in all the subphenotypes of diabetes, helping better glycemic control and also helping in preventing the long-term complications of diabetes. We're going to see what is the different phenotype, diabetic heterogeneity. We'll talk about the subphenotypes now. We have a phenotype where severe insulin deficient diabetes. That is usually the type 1 diabetics or the ones who are very actively overworked diabetics. They are characterized by profound beta cell dysfunction and low insulin secretion. That is a group where the patient becomes very thin, cachectic, and he loses weight. And then these patients usually type 1 diabetes, but sometimes type 2 diabetics, if poorly controlled, can also land up in this severe insulin deficient states. In this class of patients, insulin glargine has been tried, and now type 1 diabetes patients also are using glargine. And this drug has shown better good results. It helps in controlling the sugar adequately. It helps in stabilizing the body weight and preventing the long-term complications. Then there's the second group where mild age-related diabetes is there, like we see in the early type 2 diabetes, which presents in the middle age or 30s or 40s. There you see that the age-associated mild metabolic impairment with moderate insulin resistance is there in this class of patients. In this class of patients, if you give glargine, it helps in controlling the blood sugar by helping to beta cells to replete, and also at the same time it helps in lowering the insulin resistance ultimately. And we have the mild obesity-related diabetes. We saw that central obesity is the driver for insulin resistance with relatively preserved beta cell function. In this class of patients, we see sometimes that the diabetes has to be controlled in a better way. And we have the severe insulin-resistant diabetes, where marked insulin resistance with hepatic and peripheral metabolic dysfunction is there. So we have different classes of patients. These are the 4 important subtypes or phenotypes of diabetes, and we're going to discuss that. The glargine efficacy across subphenotypes has been studied across all the 4 groups, and the differential response patterns have been seen. And most of the patients, different phenotype patients, have demonstrated suboptimum A1C control with basal insulin monotherapy, often requiring intensification to basal bolus regimes. Sometimes it's not just possible to control with one basal dose of insulin. Some patients require the basal bolus approach where 3 shots of prandial insulin are given prior to the major 3 meals. And 1 basal insulin usually at bedtime are given to control the basal or fasting sugar. Even with intensified therapy, most of the patients frequently remain above glycemic targets, highlighting the severity of beta cell loss. These patients are usually very high brittle diabetics who are not at all stable from every point. Sometimes MARD and MOD subphenotypes typically achieve better glycemic control, with the insulin glargine reflecting their relatively preserved beta cell function. So among the 4 types, the ones which you saw, the initial ones where the beta cell mass is not reduced, only insulin resistance is the factor. There, if you give basal glargine, there probably the results a little better compared to the ones who have totally exhausted the beta cells and were depletion. And the insulinopenia is very marked in that group. It is sometimes difficult more to control the sugar with basal bolus doses. So depending on the type of the phenotype, Different result patterns are seen in different class of patients, but it is worth trying in every class of patients, and glargine does help. It does its best to control blood sugar in all the 4 classes of patients. Glargine efficacy across subphenotypes. This was the one we just discussed. The next slide. So the clinical implications is you have to tailor the insulin therapy according to the need, requirement, and demand of the patient. You have to recognize what subphenotype the patient belongs to. Number 1, the clinical and metabolic characterization guides optimum insulin regimen selection. Recognize the phenotype. Number 2 is early intervention. Consider basal insulin early to prevent the decline of the beta cell, as we just talked about. Number 3 is something that we have to take effective steps to prevent the micro and macrovascular complications. What are the practical clinical considerations? We'll be discussing that. How to translate evidence into practice strategies for successful insulin glargine initiation and optimization is something that we're going to discuss today. Insulin glargine initiation in early type 2 diabetes is something that we're going to talk today. Early initiation principle: don't delay insulin therapy when oral agents fail to achieve target. Early basal insulin protects beta cell, as we said. Many of the patients are already on 2, 3, 4 drugs, and a lot of oral OHAs are being used more than 3. When you call it a case where the patient is landed into glucotoxicity, secondary OHA failure. Rather than changing oral hypoglycemics or giving 1 or 2 more other oral hypoglycemic, you have to decide that it's time to call it a day and the patient should go on basal insulin. That is the best way to insulinize the patient, as we said. That will help in controlling the glucotoxicity and also will help in beta cell regeneration, ultimately better control of sugar. You have to identify the appropriate candidates. Patients with inadequate glycemic control despite optimum oral agent therapy, as I just said. This is a class where you have to give this basal insulin from the very beginning. You have to start conservative dosing. You start with 10 units, that's a standard dose, or you give a dose of 0.1 to 0.2 units per kg. Once daily, typically at bedtime, is usually chosen of insulin glargine. 0.1 to 0.2 units per kg, or 10 units you start the basal dose, and then check the fasting sugars every couple of days and see if the fasting sugars are coming between 90 to 110. If it's still on the low side, you try to decrease the dose. If the sugar control is not adequate, increase by +1, +2. Ultimately, you'll end up with the right dose. And titrate based on response of the patient. So titrate, adjust dose guided by fasting glucose target, as I was saying, and hypoglycemia monitoring. You have to make sure the patient is not experiencing hypoglycemia, especially nocturnal hypoglycemia or early morning hypoglycemia. If that happens, then you reduce the basal dose at night. If the patient is still not well controlled, you have to increase the dose by +1, +2 units every couple of days until the perfect control is achieved. What is the perfect control? If you can bring your fasting sugars between 90 to 120, if you bring your postprandial between 120 to 160, if you bring down the A1C to below 7, or at least preferably near 6.5, that is the perfect control one should try to achieve. Also, you have to monitor constantly whether the patient gets hypoglycemia. And what better way nowadays, we are depending not just on the sugar values, we are also calculating the time in range, which gives us the idea of glycemic variability by plotting the glucose curve throughout the 24 hours. Time in range is a period most of the patient stays in the right glucose range. The right glucose range, you have to be in that 80 to 180 milligram range. That is the time in range for most of the period of the time, between 16 to 18 hours. The higher the time in range, the better the glycemic control. And by assessing the time in range and frequent monitoring of blood sugar by doing self-monitoring of blood glucose at home, you can achieve the perfect level by consulting your doctor and doing it in the right way. What is the combination therapy strategies? So you can either give glargine plus oral agent, give the patient on some metformin and DPP-4 inhibitors to optimize glycemic control while maintaining weight gain and hypoglycemia risk. So if you start with insulin glargine, you can continue with the metformin and DPP-4 inhibitor like gliptins. That will help in controlling the blood sugar more effectively because it is acting by 2 mechanisms. One, the drugs are acting by reducing the insulin resistance, and the glargine is acting by improving the insulin sensitivity and helping the beta cells to regenerate and produce insulin ultimately. You can give the basal plus approach, where you can add a single prandial insulin dose at the target meal for persistent postprandial hyperglycemia. As I said, you start the basal insulin at night and control the fasting sugars initially. Once you've done that job, you see the postprandial is causing the problem. And for that, you can give this basal plus approach, where 1 dose of prandial insulin is given just before the major meal at lunch, so that prandial sugar is also controlled and ultimately the patient achieves better glycemic control and better A1C levels. because A1C, HbA1c is dependent not just on the fasting sugar but also the postprandial sugar. So in order to get a better HbA1c result, initially in the first phase, when the HbA1c is very high, 9 to 10%, fasting sugar has to be fixed fast with a basal insulin. Once the fasting sugar is well controlled, you see the A1C hovering near the 7.5, 8% mark, then you know that it's time to address the postprandial. And if the postprandial is not well controlled, you have to give sometimes the basal plus approach where a prandial insulin can be given with the largest meal. And the basal bolus intensification is the final step. That is the most intensive therapy where 4 shots of insulin are given. Full basal bolus regimens have to be given in some difficult brittle diabetic patients where the control is very erratic and there's a lot of glycemic variability. In those classes, you have to give the basal bolus therapy. So you can choose either of the 3 approach, Glargine plus oral, basal plus approach, or either basal bolus intensification. Patient education and adherence is also very important. Patient has to be well explained at every step how to control his blood sugar in a very effective and better way. Essential education components are proper injection technique has to be explained to the patient at any time of initiation. The site rotation has to be explained. You should not inject at the same site, and the needle disposal, you should dispose the needle, microfine needles every 2-3 days is also important. These are the 3 very crucial steps: proper injection technique, explaining that you have to change the site, and also asking him to change the needle every couple of days is also important. And then the optimum dose timing and consistency with daily routine has to be adjusted. What is the best time to inject depends from patient to patient. Normally, we tell the patient that you give it in a particular time of the day and don't try to keep the insulin injection within that 1 hour time. If the patient is giving it at night, then you should keep it at that time. It should be consistent with the daily routine. Hypoglycemia recognition, prevention, and treatment strategy should be explained to the patient. In spite of everything of hypoglycemia occurs, you should identify the early signs of hypoglycemia and take right steps by taking glucose drinks or so that the patient doesn't land up into severe hypoglycemia has to be explained to the patient. And then the blood glucose monitoring and pattern recognition has to be explained to the patient by explaining the SMBG or self-monitoring of blood glucose techniques. Nowadays, glucometers are very handy, and we have to explain the difficult patients to keep glucometers at home so that they can check their sugars at different times of the day so that they can get the perfect control and they know how to adjust the insulin and the oral drugs accordingly. And the last is storage and handling of insulin products is also important so that the insulin is preserved over a period of time. So all these important communications should be addressed to the patient and address common fears and misconceptions about insulin therapy through sympathetic discussion. Evidence-based information is very important. In every clinic, if the doctor is busy, you should have to take the help of nutritionists or sometimes insulin care specialists who come and explain the techniques of insulin injection and discuss the pros and cons of insulin therapy so that the patient is well informed. He doesn't, because there is a big fear on the part of the doctors and the patients when insulin is initiated. He thinks probably that is the end stage, at the end of his life. But if properly explained and counseled, then we can bring the patient out of this crisis and he can understand the benefits of good insulin therapy, better diabetic control in the long run. You have to emphasize insulin as a tool for health preservation, not a sign of failure. To talk to the patient that if you give insulin, it's an anabolic hormone injection, and that will help in preserving your body functions and preserving and giving more organ protection so that you can lead a more healthy life. That is to be well emphasized to the patient, and ultimately he'll see the benefits of insulin therapy and he'll start taking it very gladly. Next slide. But you have to talk and discuss with the patient at every step so that he takes you into confidence. The real world impact and future directions are there, looking beyond current evidence to emerging innovations in beta cell preservation and insulin therapy optimization is always being talked about and discussed. We are working on it every day. More trials and investigations are on to see what are the better therapies of beta cell preservation. And definitely at the moment, basal insulin stand as one of the best lines of approach to preserve beta cell and optimize insulin therapy and produce better glycemic control. So the long-term outcomes of the early basal insulins are also being studied. The delayed insulin dependence is something which is important. The potential to postpone need for intensive insulin regimen for beta cell preservation and reduce glucotoxicity burden is so important. If you give insulin from the very beginning, basal insulins will help in preserving the beta cell, as I said. The patient doesn't land into a difficult stage where basal bolus insulin has to be given. So it can be just maintained with basal insulin plus oral or basal prandial regime. Number 2 important thing is the complications are reduced. Better long-term glycemic control achieves better complications, especially microvascular and macrovascular complications as we discussed. Because if you lower the A1C by 1%, there's almost 20 to 30% reduction of microvascular complications directly. And also, if you control your blood sugar adequately well, along with the blood pressure and the lipids and your body weight, you can prevent the cardiovascular complications very significantly, and also the renal complications. The quality of life improves, improved symptom control, energy levels, and overall well-being with stable glucose management is achieved by the patient. The patient's symptom control is so important. Patient starts feeling more energetic, and overall well-being of the patient is also established with basal insulin. And healthcare cost savings are also so important because prevention of complications reduces long-term healthcare expenditures and resource utilization. So ultimately, it's going to benefit the patient and the community and the healthcare system. From the very beginning, if you can explain and talk to the patient and tell him that you need insulin so that you can prevent all the long-term complications, both micro and macrovascular, also the fatal complications like severe cardiac attack resulting in death or sometimes heart failure related deaths or renal failure leading to dialysis. All these things can be avoided if you can start insulin from the beginning and control your sugar for better glycemic control, and you'll understand and you'll see the point. So emerging research on beta cell regeneration and preservation is ongoing and continuously going on all over the world. And future research frontiers are being talked about where scientific investigation continues into insulin glargine's potential role in promoting beta cell rest and facilitating functional recovery. Novel therapeutic combinations targeting multiple pathways of beta cell health are under investigations, including the GLP-1 receptor agonist for beta cell protection and SGLT2 inhibitors for metabolic relief. Experimental regenerative therapies are also being worked on. So when you say a lot of therapies are being thought about, because we're trying to find the perfect panacea for beta cell regeneration. Basal insulins do help. GLP-1 receptor agonists also help in beta cell protection. Also, SGLT2 inhibitors help controlling the metabolic load, preventing greater cardiovascular renal protection, reducing body weight. That also indirectly helps in beta cell preservation. Other more experimental studies are on the way so that we get more and more better drugs in the future. The summary and the clinical takeaways are now, after discussing the whole scenario, I'm going to talk about the most important takeaways that you should remember. Remember that consolidating the evidence for beta cell first approach using insulin glargine in type 2 diabetes management remains the sheet anchor of management. That is the thing you should understand, that you have to tackle give insulin glargine from the very early stage so that you can prevent glucotoxicity and also on the long term aim for better beta cell preservation. That is the main crux of the problem. And you have to, if you want to understand the basic thing, then you can help your patients initiate basal insulin from the very beginning to protect them in the long term. Key points again, I'm trying to recap and give you the important things. We talked about beta cell preservation is central to the problem. We talked about protecting remaining beta cell mass and function is the cornerstone of managing early type 2 diabetes and preventing progression. So that is the main thing. You have to understand the important crux. Beta cell mass has to be preserved at any cost. You cannot let the beta cells decay or insulinopenia set in. So for that, you have to initiate measures. And early initiation matters. You have to give basal insulin from the beginning rather than wasting time or delaying that therapy. Starting basal insulin therapy early can improve glycemic control, help in enhancing insulin sensitivity, and also potentially after disease trajectory is also improved. So all the complications are reduced if you give basal insulin. Insulin sensitivity and the glucose, the beta cell regeneration effect is also improved by giving basal insulin. Insulin glargine provides dual benefits. It offers effective basal insulin replacement while reducing glucotoxicity to enable beta cell recovery and improve endogenous secretion. So if you give basal insulin, it helps in improving the glucotoxicity in one hand, reducing insulin resistance. On the other hand, it helps the beta cell to recover and improves the endogenous secretion. And the personalized approach is very important where tailor insulin therapy intensity and combination strategies to patient phenotype, clinical profile, and treatment response. Depending on the patient's phenotype and the response and the type of the patient, decide on giving the right insulin, right dose of basal insulin, and also the right combinations with basal insulin. I think these are the important things that we discussed today. The clinical algorithm, when to start insulin glargine, is the important thing. If you see that the patient is not well controlled and the fasting hyperglycemia is persisting hyperglycemia in spite of 2 or 3 oral hypoglycemic drugs, if the fasting sugar is still more than 250 or 300 all the time, and you have to know that this is the time the patient should be initiated on insulin glargine. This is the time to initiate insulin glargine. And then the patient's readiness and safety has to be discussed with the patient. To tell him that it's a safe insulin and you can manage it on your own without any contraindication. Beta cell dysfunction markers have to be explained. The high risk or evidence of failure has to be talked to the patient. And then you discuss the glycemic criteria with the patient, the beta cell markers, and the patient factors. The glycemic criteria are fasting sugars. If it is more than 7, or as I said, more than 250 or 300, you have to say that it's time to go to basal insulin. If the A1C is more than 7.5 in spite of maximum oral therapy, 2-3 drugs, sulfonylurea, metformin, DPP-4, you have to know that the patient has to go on basal insulin. The oral therapy is not enough in this patient. Beta cell markers have to be seen. What are the markers of beta cell degeneration? The C-peptide will be low, the insulin levels and fasting sugar will be high, the insulin levels will be low, and the C-peptide will be low, and elevated proinsulin and C-peptide ratio will be there, and SID phenotype is there. So if you see this class of patients where the patient has got a very lean SID phenotype, the patient's insulin signs of insulin resistance and decay have set in. C-peptide is getting progressively low, insulin levels are getting low, and you should not waste time in starting basal insulin. And the patient factors have to be that patient has to be motivated, capable of self-injection. No severe hypoglycemic unawareness should be there in the patient. The elderly patients have to be a bit cautious. Some of them suffer from autonomic neuropathy and hypoglycemic unawareness, so risk of hypoglycemia has to be explained. But if you can explain the self-injection technique and the complications well to the patient, he takes it well and he starts using it very effectively. The future perspectives, what are the areas that we're looking into? Personalized medicine, integration of type 2 subphenotyping into routine clinical practice for individualized treatment selection is very important. Every patient's treatment is individualized. No patient, there is no sacrosanct treatment for every patient. Depending on the type of patient, the phenotype of the patient, the work pattern of the patient, the BMI of the patient, the calorie requirement of the patient, you have to choose the right approach, right therapy, which could be a combination of basal insulin or oral drugs. So depending on that, we have to tailor the therapy. So everybody's therapy is different, so you have to choose and personalize the therapy for each patient. Number 2, combination therapies are in vogue. It's not just one basal insulin which is going to do the trick. You have to pair the basal insulin with beta cell protective agents like GLP-1 agonist or SGLT2 inhibitor or a DPP-4 inhibitor, which are good beta cell protectives, or metformin for synergistic disease modification. As I said, one has to choose 2 of the things. One drug, insulin, basal insulin, is helping in beta cell regeneration and ultimately more release of endogenous insulin, improving the beta cell secretion on one hand. On the other hand, you have to choose drugs which will help reducing insulin resistance like SGLT2 inhibitors, GLP-1 analogs, DPP-4 inhibitors, or metformin. You have to avoid drugs like sulfonylureas or regular insulins which cause beta cell depletion. Ongoing trials of their long-term cardiovascular outcome and beta cell function studies are being worked on to clarify optimal treatment strategies. This drug, Insulin Glargine, the cardiovascular outcomes, the renal outcomes are quite good. It can be used very safely in the class of patients who have got diabetes with significant cardiovascular or disease and renal disease. And technology integration has to be achieved by AI-driven insulin dosing algorithms and closed-loop systems for optimized glycemic management. So nowadays, the work has become much easier with better and better insulin-driven mechanisms, better and better insulin pen devices, and better understanding of the disease, so that everybody can be synchronized very well into the lifestyle of the patient. The patient can lead a more healthy life, free of disease and its complications, and can manage diabetes in a more confident way by using this mechanism. And I think that was the last slide. So now that I've talked to you exhaustively on the benefits of beta cell preservation and how to preserve a beta cell by using basal insulin from the beginning, I think that is the core message I'm trying to give to all of you, that you have to respect the patient, you have to treat diabetes very aggressively from the beginning. You have to make sure that the beta cells are well preserved over a period of time so that you can help the patient lead a more stable life free of microvascular and macrovascular complications. So from that approach, you have to choose agents which help in beta cell regeneration. Basal insulins are one of the first agents to be thought about in the situation of glucotoxicity and beta cell loss. Along with that, certain other drugs which I said can help along with in beta cell preservation, like SGLT2 inhibitors, DPP-4 inhibitors, GLP-1 analogs, or metformin, can be given synergistically together. So I think one has to understand the crux of the problem, how to preserve the beta cells by giving the right drug, rather than blindly or randomly giving 3-4 oral hypoglycemic drugs and making the patient worsen progressively over a period of time. So you have to realize that this is the time You should stop adding more and more oral hypoglycemic to your prescription for patient satisfaction. You have to realize and talk to the patient that he needs more beta cell protection. Best treatment would be to give basal insulins like Glargine, which will help him come out of this crisis and help him lead a better and healthy life. Thank you for your patient hearing. If there are any questions, I'll be happy to take up. Thank you.